The BloodStream Podcast is brought to you by Shire. And for that we say, thank you, Shire. Hello and welcome to the BloodStream Podcast, episode 30, November 19th, 2018. I'm your host, Patrick James Lynch, and I'm flying solo this month. Just as Natalie was last month for our Bleeding Disorders Conference episode in Orlando, Florida, I am bringing you audio from my experience during the New England Hemophilia Association's FallFest from earlier this month in November. Natalie was not there for that. She will be back with me for a traditionally formatted episode to end the year next month. But here in episode 30, we're bringing you along on my experience during NEHA's FallFest. I was there to run a Stop the Bleeding workshop with teens and present some Teen Impact Awards, to moderate a panel on new and emerging therapies in hemophilia care. That was particularly interesting, and we've got some great audio from that. And to screen Bombardier Blood. So we've got audio from these events to bring you, as well as an awesome share piece from NHF's Nicole Scappe. All that and more coming up on this episode. Welcome to BloodStream. While my NEHA FallFest weekend kicked off with a Friday night screening of Bombardier Blood, which went very, very well, and thank you to everybody who showed up early to FallFest to attend that screening, I only captured a little audio from it and ultimately just chose to leave it out entirely. You have heard me talk about the movie a ton. I am going to talk about it a ton more, and it felt like something I could spare you from on this episode anyway, so you're welcome. We will pick it up instead with audio from Saturday morning, starting with when I connected with my esteemed colleague, the one and the only, Mr. David Beatty.
All right, so it is now Saturday. What time is it? It is 11:45 a.m. Screening last night went well. Didn't record anything after. You heard a lot about the screening from NHF, so that's probably enough screening for the time being. But I'm here now and joined by my colleague, who is looking very focused and not like he wants to be interrupted for the purposes of the podcast right now. Dave Beatty. How are you, Dave?
Doing well.
What are you doing, Dave?
Well, right now I am fixing the date and time because it's still on Los Angeles time.
What is that?
So this is the Sound Devices 664 mixer recorder. And so right now, it's hard to do while I'm talking, but
Dave is our sound wizard. What could you even guess, like, what number trip this is for you with Believe? Is that even like possible?
In the 30s, probably, if I was gonna guess.
Yeah, that seems about right. What all right, let's put Nepal aside because Dave worked on the movie too. So let's put Nepal aside. Which of them is currently kind of most prominent in your mind? Not necessarily your favorite or like the best one, but like what's just today top of mind for whatever reason?
Well, I had a great time in Idaho, and it was very surprising to me because I don't normally think of Idaho at all, just like in general. But when we got there, like not only were everyone was super nice, and the hotel was gorgeous, but the food was incredible. And I was like, wait, I don't really like Idaho, really? Has good food? I didn't think of that. Not just potatoes too, like the bacon, best bacon I've ever had still.
So you're home. You're in your home state. We're here only for a few days. What are you most looking forward to today?
Well, let me tell you this. So when we first got in last night, I was taking my bags out of the car, and then I heard a sound, which I hadn't heard actually in like years. And it surprised me because I was just standing there. My dad's like, what are you doing, Dave? And it was because hearing the rain hit the leaves. Because, I mean, in Los Angeles, we have rain, but there's not like woods. And I live in the woods. So just listening to all the raindrops hitting the leaves, just like I was standing there just in bliss. Just like, oh my God, I remember this sound.
Dave is home, everybody. Dave is home. All right, I'll let you get back to your work. Thanks, Dave.
And to be clear, Dave and I are very pro-Idaho. Thank you, Idaho. Oh, also, thank you, Shire, for supporting this and every episode of the BloodStream Podcast, the flagship pod of our community's first and only bleeding disorders podcast network, BloodStreamMedia.com. Thank you, Shire. Thank you, BloodStream. End of plugs. Our Stop the Bleeding workshops give participants, sometimes groups of teens, sometimes groups of little kids, sometimes full families, a chance to watch some of the episodes with either me or a Believe facilitator, and then to use those episodes as jumping off points for the important conversations that they're designed to bring up. Here's a little audio from the very beginning of our discussion after screening, for the first time, one of our best episodes, Generic Hospital Part 1. You should watch that episode if you haven't yet. All right. Yeah, that's my favorite episode we've ever done because it's just so much stuff happening.
Patrick, I appreciate your performance.
Thank you. Thanks. Yes.
Do you have a post to her?
No, but I have actually proposed to somebody, just nobody in that show. Yes.
Did you hurt yourself?
No.
In any time?
No, so we take safety very seriously on a show where I'm in charge of it as a hemophiliac. So no, but yeah, there's obviously a lot of moving parts, but we treat the safety really seriously. Of course, the best part of the workshops is when the teen participants just drop some pearls during the talkbacks, like this kid who is responding to another kid's comment about how to describe hemophilia to friends.
A way to simplify it when talking about having a bleeding disorder is just saying that you don't have a certain protein in your blood. Then people can understand it a lot easier.
That's actually, I have found that to be true in my experience, is when people are like, what is it? And it's like, I'm missing a protein. Like, people know the word protein. It's on the back of ingredients and things you eat. So that's a word people can wrap their heads around. So that's a great point. What do people need to know? Why do they need to know it? During FallFest's awards presentation, NEHA Executive Director Rich Pizzillo invited me to present NEHA's 8 2018 Teen Impact Award honorees with their awards. Considering all but one New England honoree were unable to make the Teen Impact Awards during NHF in Orlando, I was pleased that 7 out of the 8 were present to receive their honor in person during FallFest. So we'll jump into a little audio captured just before the presentation. All right, I'm here now with Dave. We're at the dinner on Saturday night. Rich is reading off some raffle award prizes. There was a lot of excitement in background up until about a second ago, and then it's all, oh, here we go. Some kind of bracelets are being raffled off right now. There's a 1980s theme, so Rich himself is in quite a dashing outfit here. I don't even know how to describe it, really. We've got a green painter's hat on of some kind backwards. I don't know, is that a painter's hat, Dave? What do we even call that?
I think it's painters, yeah.
Yeah, I'm shoving the microphone in Dave's face while he's eating because people like that. Yeah, we've got a lot of great kids' costumes. Man, these kids were born in 2014, and they're doing 1980s stuff. Man, I feel old. Okay, all right, 411. Somebody with 411 may have just won something. Are you here at dinner, 411? That's that guy in the hat. Oh, he donated it, and he's getting it back. How about that? That's how boomerangs work.
It's interesting to see what styles prevail still into when you think about the 80s, what is still visually
what's pulled through to 2018.
Right. We don't see a lot of hair metal rockers,
no.
Really, but there's a lot of Madonna pop kind of, or b-boy style.
And why do what do you attribute that to, do you think?
I don't know. I mean, I guess we would have to ask the parents who helped them pick out what they thought of when they think of the 80s. I don't know.
Yeah, that's a good point. All right, well, we'll get our best people on that.
I do see Ghostbusters, though. Points on that kid. He's got a Ghostbusters t-shirt on.
Okay, we like that kid. We're into that kid. Oh, he does. He also looks fun. He just looks like a fun kid.
Yeah, definitely.
From New England received awards at the Teen Impact Awards and could not be there. So Patrick is going to present them to our teams from New England tonight. So Patrick, I'm going to turn it over to you.
I'm going to hand this to you. Absolutely. All right, I'm going to do it with your assistance, my friend. Let's give it up for Rich Pizzillo, not just for being the executive director that he is, but how about this costume? Here's a guy who knows how to lean into the theme. All right, so as Rich was saying, so I host the Teen Impact Awards, which every year at NHF's conference recognizes teens from our national community who are doing incredible things for their local community. And we have 7 individuals from the NEHA chapter here to recognize. So when I say your name, if you wouldn't mind standing up and come up to Rich here, who will present you with your award while I just read a couple lines from the bios. And first up, we have William Addison. William, where are you? William? All right, round of applause for William, everybody. Grab your certificate from your edge. William is a year away from being an Eagle Scout and a third-generation member of the Order of the Arrows. He is a hiker and budding mountain climber, inspired, it says here, by none other than Mr. Chris Bombardier. William, everybody. All right. Ismael Castillo, where are you, sir? Where's Ismael? Is he in the room? Maybe he stepped out of the room. All right, well, I'll read his bio. If you're in the room, come on up. Ismael Castillo believes in paying it forward, volunteering at his camp to pass along the joys that it's always given to him. He takes care of the grounds, cleans cabins and the dining hall, and plants flowers to recreate the special experience that he had at camp. Is Ismael here? Is that you, sir? All right, round of applause for Ismael. Next, we have Sarah Firth. Sarah, where are you? I've seen you. I know you're here somewhere. There you are. Sarah, her brother has von Willebrand disease, so she started a rare disease awareness club at her high school, and she regularly pitches in at NEHA events at camp because she is a Teen Impact honoree. Sarah Firth, everybody. I shared an elevator ride with this gentleman on the way here. Where is Eric La Liberté? Eric? There he is. Our friend Eric here. Eric loves to hike with the Boy Scout Troop 303, a troop for guys with special needs, and has participated in the Special Olympics for 6 years, bringing home a bronze medal for the 100 meter, the silver for the mini javelin, and the gold for standing log jump. Eric La Liberté. Next we have Matthew Messina. Where is Matthew? Right over here. Matt created the Infusion Closet, which collects excess or unwanted medical supplies and delivers them to humanitarian organizations in need, ranging from the Global Health Society to hospitals in South Africa. Matthew Messina, with an excellent pair of sunglasses to add. Next up we have Shane Secanaro. Shane, where are you, sir? Shane, here he comes. Shane has just completed a service project in Ecuador, where he helped to build a school stateside. He helps prepare the grounds at family camp, where he is also a junior counselor. Shane, everyone. All right. And last up from this group, certainly not least, Andrew Tham. Where are you, Andrew? Where's Andrew? There he is. Andrew excels at non-impact sports. He is a lifeguard and a competitive league bowler and spends his time teaching young people the ins and outs of each sport. Andrew's also a member of his high school hyper robotics team, and yes, he mentors young people in that too. Ladies and gentlemen, these are the 4th annual Teen Impact Award honorees from the New England Hemophilia Association.
Leave your fingerprint. As a child, and more specifically as a teenager, I spent a great deal of time in the emergency room. By the age of 13, I had been to the emergency room 16 times for, quote, possible fractures that could not be determined related to severe soft tissue swelling and bruising. My parents would always say, "You need to decide when the pain is real, Nicole." I vividly remember the hospital staff asking me, in a whisper, if I felt safe at home and if anyone was hurting me. In spite of my numerous hospital visits, it was actually my mother's health issues that led our family to a von Willebrand disease diagnosis. We were a bit confused at first, but with the help of my local chapter and Hemophilia Treatment Center, I was able to get the care and support necessary for my bleeding symptoms and specific bleeding disorder. Through the HTC, I discovered that all those misdiagnosed fractures were in fact joint bleeds, and that only my using Factor would prevent and treat the bleeding. Factor replacement made an immediate difference and continues to make a difference in my quality of life. Sometimes I think I'm Wonder Woman and overdo it, but generally, if I stick to my treatment plan, I have no complaints. I do have joint damage from all the bleeding episodes, but constant exercise and prophylaxis treatment helps. Earlier, I talked about getting support from my local chapter. I remember like it was yesterday when the Western Pennsylvania chapter of the National Hemophilia Foundation invited me to their education weekend and camp. I could never have anticipated that after only 2 events, helping those in the bleeding disorders community would become my passion. I found only after doing a few small events that public speaking, mentoring, and teaching would become my niche. I idolized leaders who worked for local chapters, camp, and NHF. I participated in NHF's National Youth Leadership Program, NYLI, moved to New York City to serve as their summer intern, and served as my camp's director of fun for 3 years. Now, I am proud and excited to be a full-time employee at NHF. My title is Education Program Coordinator. I work with my manager on all of the inhibitor summits as well as rare bleeding disorder pre-conferences at NHF's Bleeding Disorders Conference. During my time as an NYLI member, I volunteered and spoke during the World Federation of Hemophilia's World Congress in Orlando, Florida. There I met other youth from across the globe and WFH staff. During the meeting, I was asked to join the WFH Youth Leadership Committee. My participation with this committee has presented me with invaluable once-in-a-lifetime opportunities. I attended their youth workshop in Barcelona, Spain, and recently traveled to Glasgow, Scotland as a Susan Skinner Memorial Scholarship recipient. In Glasgow, I spoke during NMO training, World Congress, and attended General Assembly. Through these experiences, I have learned so much, met lifelong friends, and been given opportunities that I am beyond grateful for. It may seem strange, but I see my bleeding disorder as a blessing. Sometimes the related health issues can make living with a bleeding disorder unpleasant and difficult, but being a part of this community makes it all worthwhile. I encourage everyone to connect with their local communities and find their bleeding disorders family. Work together to make a difference so others may not have to face the challenges that so many of us have endured. When I speak to others throughout the world and across my own country, I always challenge folks by asking them, where will you leave your fingerprint? Your fingerprint is unique, so I encourage folks to think about where and how they want to leave theirs.
Thank you, Nicole, for sharing your story with us. And a reminder that you can read Nicole's piece if you would like to or prefer to, or you just need to, on our blog page at BloodStreamPod.com. That takes us to the current and emerging therapies in hemophilia care panel that I hosted, featuring 3 local HTC clinicians, 2 docs and a nurse, each taking 10 minutes to discuss Factor, Hemlibra, and gene therapy, respectively.
Just a couple minutes away from the Emerging Therapies panel, the new and Emerging Therapies panel that I'm hosting here. Dave is talking to the sound guy here at the hotel, also named Dave, because we're playing a little microphone game while Rich is going over the slides with the presenters. See, this is nice. Other people have slides and responsibilities. I basically just have to say, and now this person talks. I have the easy job. Everybody else has to do the hard work.
The goal of this session was to identify some of the knowns and unknowns of Factor, Hemlibra, and gene therapy, respectively. Our first panelist was Laurel McKernan, a nurse working at the Dartmouth-Hitchcock Medical Center. She kicked off the session with a review of factor replacement therapy, more commonly known simply as Factor.
Okay, so welcome everybody. I'm really excited to be here. I hope everybody can stay awake after lunch. First of all, I want to say this is really an amazing time, right? To add to the Factor products we already have is this huge list that I can't even read from here, right? Of the 8 new Factor 8 products and the 5 new Factor 9 products. So my goal now is not to review all of these products. There's lots of information out there. You can talk to your HTC about it. But instead to talk about how do we handle it when we have the ability to make a lot of choices, good choices within hemophilia for care. Historically, in making decisions about illnesses, those of us of my generation remember when the doctor would come in and just tell you what to do, right? That paternalistic approach. You didn't have to make any decision or have any input, which wasn't a great way to handle things. Sometimes when there's a life-threatening event, this is still appropriate. If a child has an infected port, if you have a head injury, a fracture, you want someone to step in and make decisions. But then nowadays, what we quickly move to is an informed approach, where the patient or parents are provided with information and entitled to decide. Now that's really where we've been, I think, with hemophilia, right? Because up until the last couple of years, the treatments have been fairly similar. You could pick pretty much any factor 8 or factor 9, and the treatment would be quite similar. So whatever flavor you wanted to choose, it was really okay and would work well for you. Well, now we've got extended half-life factor products. We've got injectable treatment that's non-factor therapy, and then there's research for gene therapy. So there's really a lot more to think about. This really moves us, I think, to the idea of shared decision-making, or a dance between the provider that's ordering your medication and what you want. So the first step has got to be knowing and understanding the best available evidence about whatever the therapy is that you're considering. Then clarifying expectations on both sides. Are you going to be able to follow the particular prophylactic regimen? Are you going to be able to record infusions that you take? And what is it that you expect to gain from it? Do you want to eliminate joint bleeding, or do you want to play sports? And then most importantly, and I think this follows really well with what Chris Bombardier said earlier, is incorporating the patient or child's individual values, goals, experiences, and preferences into the decision. So when you want to go for your gut monkey that Chris talked about, what are the things that you need to be able to have in order to manage your hemophilia so that it doesn't get in the way? One of the big tools that we have to get more evidence about factor is PK testing. PK testing combines pharmacology and kinetics. It means looking at how you as an individual utilize a particular factor product. And it involves measuring the blood to find out how much factor is present at a time. I didn't know I was going to have to hold this mic because I had planned to move my hands around, so I'm going to do that. So a peak is the highest point, right after you infuse. That's when you have the most protection. And then the trough is the lowest point, usually before your next dose. How low does that fall? Is 1% high enough for you, or does it need to be a bit higher than that? The midpoint is the point in time when half of the factor is gone. So if you started at 100%, midpoint you're at 50%, and then you end up with this trough. A lot of people feel that one of the most important numbers out of those three is the trough. How much protection do you have at the lowest point to go about the things you want to do? So the value of the PK studies is really, really critical when managing young children. We know that children under the age of 6 years have the shortest half-life. And typically babies and toddlers are even shorter than our little, than the 6-year-olds. And what happens is that kids have a higher metabolism, they're more active, and they may commonly need a higher number of units per kilo of their body weight to maintain the same level. When they get older, they may need less. So we use the expression growing into the dose. Sometimes a 4-year-old may be on the same dose that they're on when they're 7 or 8 because their recovery improves. We know different people bleed more. Some people have more of a bleeding phenotype, bleeding more often, sometimes even within families. The genetic makeup can influence how you metabolize it, and different people will respond differently to different products. So you may read about recovery studies with a particular product, but it may be very different for you or your child. So some centers recommend that if you're on a current product, it's working pretty well for you, or it's not, get the PK studies on the product you're on, and then try a new product and see, are you going to achieve what you're really hoping to achieve? For example, a longer or higher trough, or better protection, or fewer infusions, whatever the goal is. So when we talk about a lot of the PK testing is really focused on people that are on prophylaxis. And I know that, and hearing Chris talk yesterday, a lot of severes, it's recommended they be on prophylaxis, but a lot of teens and adults don't consistently stay on prophylaxis. I think we're the most successful with really young children, where they start prophylaxis by age 3 before there's any joint disease. But for adults, lots of times it's really secondary prophylaxis. They've had some joint bleeds, or even tertiary prophylaxis. They've already got joint damage. And if we look at this slide, so you can see the bright red. This is some data that's collected by all the hemophilia treatment centers, and there's a large number of patients, thousands of patients enrolled. What this tells us is that the percentage of people being followed at the treatment centers that had the benefit of starting primary prophylaxis prophylaxis before the age of 3 years and before 2 joint bleeds is really quite small. Only 9% of people in their 20s and early 30s. Now that number is going to get better over time, but we know that a large number of people didn't have the benefit of primary prophylaxis. We do know that the use of prophylaxis does predict decreased bleeding at any age. What I'd like to take a minute to talk about is Dr. Manko Johnson, who was one of the leads in the original prophylaxis study out of Denver, looking at little kids and how much better they did on prophylaxis versus demand. She's like, well, what about people that already have joint issues? What about all of our older patients that are either at secondary prophylaxis or they actually have joint issues? How much is it going to benefit them? And amazingly, you'd think there'd be a lot of literature on this, and there's not a lot. This was published in 2017. There were 70 teens and men that were on demand therapy. There were 35 in each group. You can see the bright red prophylaxis group versus the demand group. And fully 1/3 of those on prophylaxis had no bleeds at all, whereas everyone on demand therapy experienced bleeds over this 3-year period. Almost 3/4 of the people on prophylaxis had 2 or fewer bleeds. I've had 1 or fewer bleeds a year, so 1 or none. Whereas the annual bleed rate average for people on demand was in the 30s. Now, there were some people that didn't have as many bleeds. They might have 8 or 9 or 10, but there was still way, way more bleeding. So it's clear that people that were on prophylaxis as adults, there was still tremendous value, even though they might already have a target joint. So why is it that some people that are adults and teens in particular, when they don't have their moms and dads to make sure it happens, start to fall off on prophylaxis? Well, this was a European study, but in my experience, it holds true in the US too. 50% of the time, adults and teens with hemophilia say they didn't infuse because they weren't having symptoms. But wait a minute, we just said if you prophylax, you don't bleed. So clearly, we're at a difficult situation because the prophylaxis is so successful, your symptoms disappear. Other reasons where people just forgot, it took too much time, it was inconvenient, discomfort with having to do injections. So to get back to shared decision making, what we really want to do is look at what are people's individual goals and how do we help them meet those goals. So a younger person or an active person, it may be they want to run, bike, hike. A young adult may want to be playing with their kids. Somebody with joint issues may want to not miss work or be able to walk on the beach. They may want minimal life disruption. And I think sometimes providers and patients come at different angles from this. We start talking about a low annual bleed rate or normal joint scores, preventing joint disease. But I think these are not mutually exclusive. If you achieve either side of it, you're achieving the same thing. And of course, being able to adhere to the treatment plan. And I think, as my closing comment, the main thing that I believe, I completely agree with what Chris said earlier, which is find out what's important to you or your child when it comes to managing your hemophilia. And I think that's what's going to help you follow whatever the routine is that you have. And then concluding, currently available factor concentrates do allow for good bleed prevention. Thank you.
Excellent. Very well done. Thank you, Laurel. Very well done. One quick follow-up while we're pulling this slide up, Laurel. One of the benefits of having as many factor replacement products, and I know we weren't getting into plasma-derived versus recombinant and long-lasting, but all of these options allow for, as you said, when people aren't necessarily responding optimally to a certain product, there are other areas to explore. It strikes me as we move into an era where there are options outside of factory replacement, there aren't necessarily the same number of options. So if somebody isn't responding as well, where does one go? I'm curious from your perspective how you're thinking about as we move into these other class options or the other class availabilities, the lack of options within them, does that give you any cause for concern?
I think that it's, again, a detailed and important conversation for a patient and family to have with their treater to say what is really important to them at that point in time. And are they ready to make that move from factor to some other product? I guess I don't have really a preconceived notion. I feel like I've been in hemophilia a long time, and for so many years we were worried about factor safety and that there weren't really choices and options. And I think it's really, really exciting to know that there are so many different options, both within factor treatment and non-factor treatment.
Next, we heard from Dr. Gary Kupfer, pediatric hematologist from Yale New Haven Hospital. He was speaking on behalf of non-factor replacement therapy, specifically Hemlibra.
First of all, great to be here. I'm really, it's so nice to be out of the hospital, out of the clinic, sitting here hanging out with everybody. One thing I always do during my visit, now I'm going to go back to the clinic for a minute, is I ask, what time of the day are you doing your infusions of factor? And it's amazing how many people do it before bedtime. And at first I want to kind of hit my head, but then I realize, of course, it's quiet, you have time, it's relaxed. We all know, of course, that by the time you wake up in the morning, your factor is down about 50%. And so, of course, sleeping not being a contact sport by and large, it doesn't make a whole lot of sense to do that. But we have to understand it's one thing to write it down on a prescription pad and tell the patient that, you know what, you need to do it at a certain time and you need to do it this way and goodbye, see you next year. Realize real life is a whole different thing. And so that's why the idea of a subcutaneous product coming out like Hemlibra is such a big deal because boy, it's something that really kind of changes the whole game, taking away that pressure of having to find a vein. And when your eyes are bleary and when you're dehydrated in the morning after a night's sleep, it's obviously a bit of a challenge. If you're the mom or dad, if you're the patient, or if you're a 75-year-old in a wheelchair with arthritic hands trying to manipulate the infusion, self-infusion, it's a big deal too. And both of those are examples that I deal with in my clinic, even as a pediatric hematologist. So I guess the message that, if there's one message to get out there today, we really do get it, that all of you in the community it's challenging. Even though we have these great products, people are doing really well. It's still a challenge. And the idea of an easier to administer product like Hemlibra, subcutaneous, it could be a game changer. So let me just explain a little bit about what Hemlibra is all about.
Dr. Kupfer then used slides to show how factor 8 and 9 work together to get factor 10 going and how Hemlibra, as a monoclonal antibody, essentially replaces the work of factor 8 and 9 without being factor 8 and 9. It mimics it, so to speak. My words, not his, but that's the idea. If you want to learn more about the science of monoclonal antibodies and Hemlibra, check out Genentech's website and explainer videos. The visuals will help. Dr. Kupfer went on to highlight two of Hemlibra's most noteworthy features, how it's administered and how long it lasts in the body.
Very much interconnected, but don't memorize that. But this is Hemlibra. This is the way it acts. It actually acts as a bridging molecule with factor 9 and with its target, factor 10, and brings them close together. That's what it does, and it's an antibody. Factor 8, on the other hand, is just a protein, and here's a better-looking slide that Laurel gave me, which I appreciate, and which basically shows you the same thing, activated factor 8 serving as that bridge molecule in the middle, or an antibody, which serves as that bridge molecule. So beyond the biology of how these two different molecules are both proteins, right? Factor 8 is a protein. Factor ACE910, Hemlibra, emicizumab. I won't say them all three at the same time every time, but I probably will slip into Hemlibra, although I don't think I put Hemlibra in the talk. But they're both proteins, but they obviously don't resemble each other structurally speaking. But an antibody is a heck of a lot easier to make. Okay, like Hemlibra. And an antibody is not only easy to make, it's easy to administer. You can actually give it subcutaneously, and it'll last a long time in the body. So antibodies are long-lived because there's these natural cycling mechanisms that will actually make it go in and out of cells and into the bloodstream, and it hangs around for a long time. And that's why you can get away with once a week or even longer dosing for this particular drug. So the comparisons are here, and I'll just touch on a couple of things. There's emicizumab or Hemlibra has no on-off mechanism. It basically goes away just like any other antibody therapy would do. There's no distinction between factor 9 or factor 10 in terms of the way it binds. It could bind in a number of different ways, but it appears to have specific activity that mimics factor 8. And there's a lot more of it hanging around, but I don't think these are the particularly salient factor ideas, other than just to note that it's an antibody and it mimics the activity of factor 8. So this has really been in the news lately. Now, I'm going to just make one disclaimer. Not everything that shows up in the New England Journal is wonderful and perfect, okay? And there are many of us in medicine who have that kind of bias, but not everything that's there is absolute. But there have been 2 landmark papers in the last year in the New England Journal of Medicine, one demonstrating Hemlibra and its beneficial activity in inhibitor patients. And we all know, I hope, that people with inhibitors are very challenging.
Dr. Kupfer went on to point out that Hemlibra has been a particular game changer for one population in particular, people with hemophilia and really tricky inhibitors.
Patients with inhibitors have significant amounts of morbidity and mortality, even in this day and age. So emicizumab turned out to be incredibly helpful and efficacious in patients with inhibitors, diminished amounts of bleeding, and relatively safe. And then in this last couple of months, a report in non-inhibitor patients as a primary prophylaxis regime using Hemlibra, turning out in a head-to-head comparison between on-demand patients versus Hemlibra patients taking Hemlibra to be, as you might expect, it was superior. And then comparison to the patients themselves who went on Hemlibra on how many bleeds they had prior. Prophylaxis with emicizumab in inhibitor patients was better than on demand. And here's just some of the data. And you'll just note here on the left that the patients who were on emicizumab had far lower amounts of bleeds versus the patients with no prophy at all. I think that's one of the criticisms of a trial like this, is that there's really not been a head-to-head comparison at the same time in a forward-looking way to see what kind of, versus patients on standard prophy, like factor 7 or FIBA, to look at the comparison there. But there's certainly, in terms of historical data that we have, it appears that Hemlibra is certainly very good. And so there was a significant reduction in the amount of bleeds. But remember, those were patients on demand. Now, in general terms, it did seem to be, this was relatively well tolerated. Just about any drug anywhere will give you a whole long list of side effects. Here, there were injection site reactions, headaches, fatigue, a cold, although it's a little hard to figure out how Hemlibra could cause a cold. But any reported illness or side effect that could be any way related to this drug was reported.
There are still questions and gray areas surrounding Hemlibra. Dr. Kupfer addressed that too.
In particular, however, there's been some concern in the community about the association of predisposition to getting a blood clot associated with Hemlibra. It turns out the patients who got this particular side effect were patients who were also taking bypass agents at the same time. So a direct connection between Hemlibra and the risk of getting a blood clot is still to be determined. And really what I thought we would be focusing anyway, and I'm sure some of these questions will come up for discussion. We can talk more in depth about them. But these are really the points that are still, and there's a lot of things I think that still make it a little bit uncertain about how we're going to deal with Hemlibra, how we're going to prescribe it, how everyone in the community is going to use it. For example, a specific dose of Hemlibra, what does that really mean in terms of protection? We don't have any real way to quantify that. When I have a 15-year-old who's playing basketball, what amount of Hemlibra gives him X amount of protection, and how does that equal to the amount of factor that I give if I'm giving him factor 8 as therapy? Because I know pretty well what that means. I don't know what it means to give a certain dose of Hemlibra. What about children under the age of 12? It turns out in that second New England Journal paper, they didn't study patients under the age of 12, yet the Food and Drug Administration has approved it for patients under the age of 12. So there's no actual data that exists for younger children. How do we treat an acute bleed? In the long run, will acute bleeds being treated with recombinant factor be okay to use in the setting of Hemlibra? How do we monitor? There's really no good testing or validated testing to look at what a dose of Hemlibra really means in terms of laboratory testing and then prevention of bleeding. What about surgery? Again, can we use Hemlibra and then throw on recombinant factor to keep everybody safe when they go into surgery? What about side effects like clot? What are the situation? What's the situation during which we have to worry about using Hemlibra, and are we going to cause problems that we did not anticipate? And finally, I think there does need to be a study done that actually, in real time, compares Hemlibra versus prophylactic factor administration. So there's a lot of unanswered questions here. I know that I and all of you are probably pretty excited about Hemlibra, and I think it'll take a little bit more time and a little bit more study to sort out exactly how we're going to use it going forward. Thanks.
Thank you. And while just as we're changing the slides, as one quick follow-up of this list of unknowns, and I'm sure in our discussion we're going to come back to this. Are there any on this list that for you are particularly notable or worth addressing maybe now?
I think they're all somewhat interrelated. Monitoring is probably number one because monitoring leads to everything else. Okay, we need to have a test which will help us define and correlate with clinical outcome. So if you get 2 bleeds a year, what does that mean in terms of where your Hemlibra therapeutic level was? So we have to make those correlations so that we practitioners can actually use it effectively and logically going forward.
Our last panelist was Dr. Jeremy Madrid, a hematologist from Dartmouth Hitchcock Medical Center, who is there to speak about gene therapy.
Hi, everybody. As mentioned, I'm Jeremy Madrid. I'm one of the new hematologists at Dartmouth. This is my first FallFest, so it's very nice to see all of you come and some familiar faces. So I'm going to take a little bit slightly different turn in terms of approaches to hemophilia, which is exciting, and I guess the best way is, trying to go over what we do know about gene therapy, and then going over some of the unknowns, which there are probably very many unknowns of the unknowns, so kind of breaking it down in 10 minutes. So when we look at gene therapy, the biggest thing is hearing about a cure for hemophilia, which is very exciting. So when I looked into just what I'm assuming most of our families do when we talk about hemophilia and a new diagnosis, it's just Googling and seeing what comes up. And there are some articles about gene therapy on ways to fix hemophilia, even mentioning cures. So very exciting to see that there is being research done with this. The thing that makes hemophilia a nice target in terms of thinking about doing gene therapy is that it's a single gene defect. So in comparison to when we think about different types of cancers that can be multifactorial and involve a multitude of different genes, and when we're thinking of either a deficiency of factor 8 or a deficiency in factor 9, we're really targeting single genes. The idea is that the therapeutic goal is modest, which also leads to part of the unknown, but as Laurel mentions with even factor products, is raising the factor 8, factor 9 levels to 1% or above 1% is shown to be enough to keep people from bleeding. And then, of course, with hemophilia, as mentioned, and as Dr. Kupfer, we're able to monitor this with our laboratory assays. So how is it done? So the idea being there are quite a few studies looking into the best approach in terms of delivering these genes. So far, it looks like the most effective is using what we call an adeno-associated virus, being that it's a pretty small virus. We know that by taking out the part that can cause infections and incorporating a specific gene, such as the DNA to make factor VIII or factor IX, and then injecting it, that it gets to the cells. By incorporating itself into the cells, then we have the secreted protein. So pretty straightforward in terms of what the approach is. Unfortunately, a lot of the studies are looking into injections via either intravenously or through intramuscularly. Most of these studies are done in mice and dogs. And so, as we know, there are differences between all of us. And so looking to see what is most effective, but looks like maybe doing, intravenously has been most effective. So when we think about, the pros of maybe we have a cure, which is very exciting, it does lead to a lot of the unknowns. One of the biggest is the long-term consequences, which as a pediatrician, if we were moving forward in children, we don't have enough research in terms of how long does this last. There have been studies primarily when looking into the factor IX gene therapy that there can be hepatic toxicity. So looking at the liver, which is kind of what the goal is in terms of making some of these products, it doesn't seem to be something that is long-term, but again, we don't know. And most of these studies also involve using mice, which we know that mice studies don't always carry over to human studies. The other idea is where is this going? And we just don't have enough research to know. We're seeing some positive effects in terms of releasing of the specific proteins, but we don't know where all in the body it's going and how do we monitor that. How long does it last? So once you get gene therapy, does it keep you above a specific percent? Right now in children, that would be my most concerning question is if you did this and someone who's growing and we expect to grow, are we able to keep them at the presumed above 3% or ideally above 15%? And how much factor is enough? We're not sure. The other question is if it seems to work initially after it's there, if it goes away, are they a candidate to receive gene therapy again? We just don't know this question. And then also the manufacturing for this. Is there enough out there to make sure that if we move forward with these types of products, that the demand and the quantity we have is sufficient to treat our population?
So one quick gene therapy related follow-up for you, Dr. Madrid. When you are looking at, we don't have a gene therapy product that's out and available, so it's all still in clinical trials, we're still in the investigational period, but is there any particular data set or indicators from any particular study that have struck you as being particularly encouraging for some reason or another?
Yeah, I think there are a couple of studies that are out there, primarily right now, the factor IX studies. So for the hemophilia B population seems to be the most promising. Boston Children's currently has a hemophilia A. Again, this is primarily what I would say is probably more of the adult population. So overall, looking very promising, but again, how we monitor or how this trickles down to children is one of my biggest, questions. As we know, most research comes from the adult studies, but we are also very aware that children are not young adults. But I think seeing what the effects are now, especially with the factor IX products, and it will be interesting to see what Boston studies come out with in terms of the hemophilia A population.
Perfect. Thank you very much. Thank you. All right, so let's now bring this into a little bit more of a discussion. I have a bunch of questions that were submitted online and some that were asked today. So this is an interesting question that maybe Dr. Kupfer will start with your response to it, but would welcome any of your responses. Are there centers using a combination of Hemlibra and Factor VIII products to continue ITI, immune tolerance induction, for patients who are trying to tolerize an inhibitor? And I think for me too, that strikes because it gets to a larger question of the importance or lack of importance of tolerizing an inhibitor. Because if you're using Hemlibra successfully, it doesn't necessarily mean your inhibitor is tolerized. So I guess there's a little bit of a two-part question. Are you familiar with clinics using a combination of Hemlibra and Factor VIII products to tackle ITI? And thoughts in general on that tolerization piece?
It's a great question, and one I should have mentioned before. And people are doing that, yes, for the reasons that I mentioned, right? There are patients on Hemlibra who do get bleeds, so you have to treat the acute bleed. There are patients on Hemlibra who are going to the operating room, so you need to make sure you've achieved good coagulation hemostasis to get what you need to get done. So there is that. Number two, yes, there is attention being paid to tolerize patients because just for this very reason that I mentioned, you have to try to get their inhibitor titer down in order to be able to use factor in a logical, predictable way. Mm-hmm. And the good thing about monitoring is that the inhibitor titers you can do those. The Hemlibra will not interfere with that testing. So you can continue to monitor the inhibitor titer that way.
That's unique because in other versions of treating an inhibitor, it's going to impact your ability to test because there's only one system that we're manipulating, right, in those cases. Whereas Hemlibra, as an antibody, it's not interfering with the clotting cascade or the levels in your system.
Well, actually, it does interfere with the PTT, as it turns out. That actually corrects it. Like small amounts of it will correct the PTT. So as a clinical monitor, PTT is not adequate for that reason, because small amounts of Hemlibra will correct. But the actual inhibitor testing, the Bethesda unit testing for inhibitor titers is still valid, even in the presence of Hemlibra.
Got it. Okay. Anything? Yeah, Laurel.
Well, I was just going to say, when I was at the World Federation meeting, at a lot of the nursing meetings, there was discussion about that, exactly that issue. Do you still tolerize a young child that develops an inhibitor? And it seemed as though, as Gary said, there were some centers that were going with the emicizumab and low-dose factor to maintain exposure. But there was a lot of discussion about, there's a significant portion of children that develop inhibitors that there's been great success with tolerization. So I think that, just as Gary said, the easy population to put on Hemlibra were the people where standard therapy, Factor VIII, wasn't working, right? I mean, that's kind of a big success story. But I think, and some of it just may be what Chris talked about earlier, crossing your arms the other way. Like it's just a shift, I think, for the providers as much as the patients to say, what do we do now when a young child with Factor VIII deficiency shows an inhibitor? Which way do you go? And I don't know. I'm not sure that's answered really.
What opinions are welcome.
Yeah.
Personally speaking, I think Hemlibra is a really attractive choice in this situation. I really do. We've struggled for so long to do prophylaxis, for example, with Factor VII. And we're scared we get scared about FEBA. And so we want something safe and effective. I mean, that's the definition of any good drug, safe and effective. And so I think Hemlibra strikes me that way. What I worry about, and what I just haven't had enough experience perhaps, but also what I don't think has been shown in any of the trials in a definable way, is real world use of Hemlibra in combination. If you're treating an acute bleed, or if someone needs to go to get their appendix taken out, how do you put that all together? I just don't think it's been studied, and hopefully it'll all work out. But I don't think we know with great certainty yet.
Yeah, in an interesting way, there was with factor replacement therapy, we were treating bleeds, and then there was a paradigm shift to preventing bleeds through prophylaxis, and now there's Hemlibra, the ability to prevent bleeds, very high, but there's now again a question about treating bleeds. So it's just kind of interesting the way the ping pong ball has moved back and forth a little bit with treatment paradigms. So this is an interesting question that I had never thought about. For the sub-Q treatments, how do we set up medical alert? If EMS sees hemophilia on a bracelet, how will that affect the patient? Will they be given factor products, or how will we know what they will be given?
So can I take that question?
No, you cannot. Who would like to take that? Anyone but Laurel. Okay, no, go ahead.
Well, I know that the nursing committee for National Hemophilia Foundation looked at medical alert. There's really only one true, not to do an ad here, but one true medical alert where you have the phone number on the back and you call and a real person answers the phone. And I think it would be critically important to have more detailed information, which you can get that way. And I personally know that works because we sometimes have Dartmouth College students come in that should know what they're doing, but when they looked at you read their medical alert and it's like, wait a minute. But you can leave a lot more information, and there's a 24-hour operator. So there's lots of cute jewelry out there that says hemophilia, but I think that's an excellent, excellent point, that you really need that second level of information. I think in all instances with hemophilia, because there's been a few tragedies over the past decades with, I think it was factor 9 patients getting factor 8. Rhonda's nodding, she remembers this too. Wow. So anyway, and I think there's a big mistake because so many medical alerts are just really cute and adorable and the kid picks it out, but you really want the one where there's a phone number you call and you get the detail.
You know, that actually kind of also sparks for me, there might not be anything to this, but there's all those other touch points that we are, you know, as a parent or as a child, you're talking with school administrators and nurses and gym teachers, and you're explaining hemophilia as best you can to try to reach your goals and justify why you need an IEP and all the rest. This precise treatment you're using is not necessarily coming into the equation too often, but I have to imagine there are some touch points, perhaps with the school nurse, and medically, how do we respond in the case of blank? A question that maybe we had well answered 2-3 years ago, but now with Hemlibra and preparing for other non-factors and gene therapy, well, the treatment protocol isn't necessarily quite so simple. So have you given any of that thought, or have patients brought these kind of things to any of your purviews?
It's your turn, Jeremy.
You're up, Jeremy.
So, I mean, I think those are all important questions that, you know, for us, you know, right now, we haven't crossed that bridge in terms of how are we formulating these plans. I mean, this is something that when we do talk about the new products with the families, what the options are with the school nurses, outside providers, is really trying to, you know, what is the best way to put together these plans of action, which, you know, honestly for us, you know, we haven't solidified, you know, because we haven't had anyone that we've made those transitions. I think the positive side, you know, again, you know, like, you know, kind of referencing Gary is, we know that the products are out there and trying to make the move. We know that we have our kids in, you know, safe spots. We're treating, they're, you know, in a good spot, but trying to stay one step ahead and getting as much information as possible so that we can start providing the education to the families. At the same time, you know, when we're back in the office, coming up with how do we manage, you know, the acute bleeds, and looking for the research of, you know, the kids that are on this now. And so constantly touching base. I mean, we know of a couple, you know, sporadic cases that are out there that we've tried touching base with the providers in just terms of what are you guys doing? And is it working? Does it look promising? You know, and then trying to incorporate, you know, that into our practice.
I was just going to say, you know, the way we teach students and residents, for example, when a patient who has been in a motor vehicle accident with hemophilia bangs their head, you know, you give factor first, ask questions second. You know, you don't send them for imaging first, you give them factor first. And so that's not going to change whether they're on Hemlibra or they're not on Hemlibra. But that does go back to the issue of, well, just where what level of protection is Hemlibra providing, in a quantitative way, relative to clinical efficacy, clinical good outcome. Do we just give our standard 100% correction factor, with factor, or do we maybe scale it back a little? Are we going to have a unintended consequence from combining those two, over the long haul or not? A lot of questions. It's not going to change that acute trauma episode, but we may see some things happen that we never anticipated.
Both Dr. Madrid and Dr. Kupfer's presentations laid out some reasons for excitement around non-factor replacement therapy and gene therapy, while also posing numerous unanswered and important questions, which hopefully give thoughtful community members reason to think deeply about their choices and to appreciate truly how new and unknown some of this breakthrough science really is. Our panel was followed by a brief discussion during which these ideas of knowns and unknowns, goals and choices started to get more specific, and I began to use myself as an example in a conversation about treatment options with the two hematologists present.
Well, and I'll say because I hope it's useful for everyone, but as an adult with hemophilia who's been on factor replacement therapy now and had an inhibitor for 7 years and knows what that was like, I feel as though I understand my treatment, my regimen, my protocol, my lifestyle, and how it all synergizes really well. And I look at even the longer actings that have come out that I have not moved forward on. Hemlibra I'm paying attention to, but that idea of security and protection, I think of how active my life is and how dramatically different it was from as a kid who was with a very poorly managed inhibitor to today. And I fail to see a compelling reason to step into a lack of security. And yet, the idea of less and not having to access veins and just less interference and disruption in general is attractive, but not more attractive than security. So I guess what I'm saying, just for the role play of it, pitch me on Hemlibra. Pitch me on, okay, there are all those questions you put up about the unknowns, surgery. I'm worried about I'm going to need joint replacement surgery in the next 15 years. I'm concerned about what that means. And I say 15 because I'm trying to stretch it. It might be sooner. But I figure if I keep saying that, maybe the gods will work with me. So what would you say to somebody like me who's curious but just feels like I know this too well? Why would I step out of what I know so well here?
So I think in terms of pitching the, Hemlibra would be,
And I'm obviously using an inappropriate clinical word. I'm coming from an entertainment world, so I use words like pitching.
Pitching,
but obviously
sure.
No one's doing that.
We'll take it. I think the attractive parts of thinking about Hemlibra itself as a possibility for me would be, the adolescent patients in terms of, the amount of times of having to stick themselves, once, the compliance of it really. And I think that, if there was compelling evidence in terms of you're able to keep the factor levels sufficient for a very active person, discussing going from 3 to 4 time prophylaxis to 1 time subcutaneous is pretty attractive. I think that being said, unfortunately, right now for me, there are still the unknowns that as a provider, my job is also to say the unknowns that at this point, I wouldn't be able to promise that using, having to do peripheral access is out of the picture because I don't think that that's the case. And so in some way, still having that education, but, the idea of, once weekly subcutaneous, from 3 to 4 times is a nice thought.
I would just add, I definitely do not push new products on patients. I do try to inform in a way that I try not to introduce my own bias.
Sure.
Number 2, I think that it's important to consider your lifestyle. And I think for most of our pediatric patients, I'll just give you an opinion, actually do better with standard factor products because I keep going back to the example of the 15-year-old who plays basketball, varsity basketball, and 3-4 days a week needs normal factor levels. And that's actually better with standard factor. So I think for every person out there in the community, there's an individual situation that we have to adapt to. And we need the dialogue going more in this direction rather than in this direction, because I think you're spot on. It really depends on what your needs are, what your perception is, and if you're in harmony with your therapy and doing well, that counts for a huge amount.
So that's really good to hear, too, that encouragement for the dialogue to come from patients, caregivers to the clinicians. You talked about in the beginning, I believe, right, that kind of traditional patriarchal kind of approach or thought process around the interaction with your doctor and your clinical team, but it really is totally collaborative, but we as patients and caregivers need to be as active a part in that collaboration if we're trying to aim for ideal outcomes.
As we were about to wrap up, I pointed out what seemed to be the theme of the hour-long session, and I think the theme of even this condensed segment here, but you decide. Here's my take.
I know we're coming up on our time, right? I do want to point out one thing that I feel like has come up a lot, which is maybe worth underscoring. Because I think part of what I came into this session thinking about is with regard to these unknowns and having to navigate so many total options, at least for some people, not everybody has all the options available to them. What are the questions you should be asking? How does one, I walk into my doctor's office, at the end of the day, I want to be healthiest, right? Like, I just want to be healthiest. So which of these makes me healthiest? All right, well, that's not a very productive question. All right, so what is the productive question? And what seems to be coming through is how much lifestyle and goals and like what do you as an individual, and to just take it back to Chris's story and Dr. Minko Johnson, working with that Denver HTC on I want to play baseball, I want to play baseball. And the other thing that came through for me working with him on his story, not everybody's a skier, a mountain climber, a baseball player, not everybody with hemophilia ought to be pushing their bodies in that way. We're all different. But for Chris, it was his ability to do that with a plan in place that kept him adherent to his regimen. He had goals that his center worked with him on achieving, however aggressive or not one may think they are, and those goals kept him adherent. And if his parents had taken a more conservative, no, you can't do that kind of attitude with him, I don't think the Chris we see walking around here is anything like the Chris that he would have turned out to be. So it's important to consider the benefits of those of us with hemophilia who want to test our limits, and really identifying what are your goals, what is your lifestyle, what are you seeking to accomplish through your therapy beyond I want to be healthy. Get more specific and give that feedback so that your clinicians can then offer you the information they have to guide you toward the decision that hopefully works best for you. It's more of a process than we want it to be. But I think if we're approaching it this way, we have a chance at some really good outcomes.
And that is all for this episode. Special thanks to everyone at Believe Limited, the National Hemophilia Foundation, Entertainment to Effect Change, the Hemophilia Alliance, the New England Hemophilia Association, and our sponsor, Shire. Thanks as well to Nicole Scappe for contributing to our Share segment and to all who contributed from FallFest 2018. Subscribe to the BloodStream Podcast, the Ask the Expert Podcast, the Powering Through Podcast, and the Bloodline special series of podcasts on iTunes, SoundCloud, Spotify, or wherever you listen to podcasts. You can email us at mailbag@bloodstreammedia.com. You'll also find Bloodstream on facebook.com/bloodstreammedia and on Twitter @bloodstreaminfo. Reminder to check out the program notes for this episode in your podcast player or on bloodstreampod.com for links and additional information about the various stories featured on this episode. My name is Patrick James Lynch, and until next time, take self-care of yourself.